I am proud to introduce Dr. Miriam Lesberg, who is the director of the Breast Cancer Center at Smilow Cancer Hospital and chief of medical oncology at Yale Cancer Center. She is also associate professor of medicine, medical oncology. With her, she also has the best patient advocate. I'm sure everyone have seen her around, Sheila McLeod. She's an MBC advocate with HER2 positive, ER positive, metastatic breast cancer diagnosed at the age of 43 in 2009. They both will be discussing debunking common folklore for the patient.
Thank you so much for the introduction. Can you hear me and see my slides? Can you hear me?
Yes, we can hear you and we can see you.
Great. Thank you, everyone, for joining out of your busy Saturday. Sheila and I are so excited to be here for this conversation with you on discussing common myths or folklore that we all have questions about. So our agenda is to really have a conversation. It's okay to have questions. Cancer and cancer treatments can be very confusing. And really our primary goal is to have an open conversation, answer your questions either here or subsequently in the upcoming roundtable. And really what we would like to emphasize above all is that there's no judgment and that every question is safe and honored. Before we go on further, I would like to tell us a little about us. So let me turn it over to my colleague Sheila so she can introduce herself.
Hi, I'm Sheila McLeod. As it says on the screen, I'm a 25-year Air Force veteran. I was diagnosed with metastatic breast cancer in 2009, so I'm an MBC survivor. I'm a clinical trial participant, and I review grants or proposals for the DoD Breast Cancer Research Program and for METAvivor. So thank you, METAvivor. And I'm a patient advocate. Thank you.
Thank you, Sheila. And when I heard about this talk, Sheila was the first person that came to my mind, and I could not have a better partner to do this presentation with you. So thank you, Sheila. So as you heard, I'm a breast medical oncologist in New Haven, Connecticut, and I study all things related to breast cancer with a primary focus on symptom management, quality of life issues, shared decision-making, and patient-centered care. So in the subsequent slides, we're going to talk about a few common myths. We're not going to talk about every single one, and that's where your questions will be so helpful. And I know many of you are aware that we have had conversations in the breast cancer community about language and that language matters. And as I was preparing this talk, I wondered if even calling these myths or folklore could be maybe off-putting to some people, because for some people, they're just questions. These are, again, it's very hard to sometimes make sense of all the confusing information that's out there with social media, websites. There's a lot of information coming at you, and it's a lot to take in, and wanted to, again, reemphasize that there's nothing wrong with questioning and wondering, and ultimately our goals are all the same. We all want the best strategies for managing the cancer diagnosis and the treatments that we are experiencing. So starting with myth one, a lot of our myth slides have subsequent slides attached to it. This one does not. And this is a common thing that I hear as I've treated patients over a decade and a half, this overwhelming feeling of, was I somehow responsible, or did I do something wrong? And what I want to say above all is that you did nothing wrong. You did not do anything to cause this cancer. But it's normal to have some of those wonderings, and it's really important to talk about it openly to trusted friends, family, your healthcare team. And I think when we talk about it, when we bring it out in the open, it can certainly feel perhaps less scary and overwhelming. I hope none of you walk away from this talk thinking that any of this is your fault. So let's just bust that myth. Next myth is, this comes up quite a bit as well, which is having a cancer biopsy or surgery will somehow cause my cancer cells to spread. It's a great question. And part of the confusion about it is what we know about breast cancer is that breast cancer cells do spread by way of blood. For example, we know that you could have all your lymph nodes negative of breast cancer. However, metastatic spread of breast cancer can still happen many years later. So this idea of blood-based spread of breast cancer it is something that we call a hematogenious spread of breast cancer. We can actually detect these breast cancer cells. There is a growing field of what we call liquid biopsies, where in addition to taking a sample of the tumor, we can actually essentially test in the blood circulating tumor DNA or even actual tumor cells. So those are facts, and these are what we're studying to personalize and improve all our metastatic breast cancer treatments. However, what I would like you to take away from this slide is that the biology of how these cells are actually spreading in the blood is independent of a procedure. It's related to their biology and their ability to survive outside of their primary tissue, and it's beyond the scope of this talk to talk about that, but it's really important to know that it's not the procedure itself that's spreading these tumor cells, but their inherent ability to be invasive. And additionally, we know that in multiple appropriate clinical scenarios, surgery can actually improve outcomes in breast cancer. This has been mostly shown in early stage breast cancer. However, there are scenarios in metastatic breast cancer where we do also consider surgery. And more importantly, we actually need these tumor tissues and these biopsies so we can actually devise the best treatments for you. And by having these biopsies, we can actually personalize your treatment and really come up with the best treatments. Moving on to our next myth. This is a big one, and it could actually be a whole talk on its own. So I will touch on a few broad themes. This is out there quite a bit, which is our diet. Making changes in my diet will cure my cancer. And there are many, many dietary programs and assertions, including elimination diets, ketogenic diet, fasting, prolonged fasting, timing of eating with treatments, combining all these in creative ways with a variety of supplements, which I will also touch on in my next myth. And many of them are without strong evidence of efficacy against cancer. There may be preclinical data, or as in like cell line data or animal data, but in terms of like really good human studies, we actually don't have a lot of strong evidence for these assertions. So for the interest of time, I'll focus on one that's out there quite a bit, and it's called the alkaline diet. And the alkaline diet says that by essentially selecting a few foods and eliminating things like certain meats and cheeses and certain grains, you can actually alter your body acid balance. And by doing so, you can actually improve your cancer outcomes. But here's the problem. As you can see by this really confusing figure here, and it's not meant to be looked at step by step, but just to give you an idea, our body has an exquisite machinery to regulate our acid balance. You can eat all you want. You can put all kinds of different dietary choices. Your body controls your pH, and even if you're testing it in your urine, it's actually not associated with blood pH. So many studies have actually disproven this idea that an alkaline diet really impacts any cancer outcomes, and it doesn't really impact your blood pH, which is the most important thing. Moving on to myth 4, supplements can cure cancer. This has been a long history of claims that one agent can be the answer to all our ails. This is, again, a very normal, natural human desire. When we have health concerns, it's nice to think that there's one thing that will take care of it. And so in the 18th and 19th century, there was these famous snake oil tonics and salespersons who would go around and make a lot of money, essentially for something that was completely unsubstantiated. And it hasn't changed that much. If you look at the supplement industry in the US, which is not regulated by the FDA, it's actually $1 billion industry. Just in the last several years, over $32 billion were spent on supplements. And the cancer survivor population, patients living with cancer, are particularly targeted by various ads and different organizations wanting to sell you different supplements because it's very lucrative. And so is there any potential benefit? I think we all would want to spend all the money in the world if it can help our health and help our cancer outcomes. So I'll highlight 2 studies for you for the interest of time. One is a study that was put out by the Southwest Oncology Group when they looked at actually dietary vitamins and supplements in patients receiving breast cancer treatments. And here's what they found, that use of supplements before and during treatment was actually associated with an increased risk of recurrence. Vitamin B12 was actually associated with poor survival. Multivitamin use was not associated with survival outcomes, but many of these other supplements with antioxidants and vitamin 212 were. So, and this is not suggesting cause and an effect. So I don't want you to go run to your medicine cabinet and say, oh my gosh, I'm taking these vitamins. However, this study highlights that there is so much that we don't know about supplements and how they interact with cancer treatments. It's very much possible, for example, with antioxidants, is that they work really well and they're actually neutralizing the oxidants that the cancer treatment is trying to cause to fight the cancer. So just a very complicated situation, but the takeaway is that pretty much every good study that we have in terms of supplements has either not shown an effect or possibly even shown a negative effect. And this is another one where it was published in 2018, where they looked at patients who were using any type of complementary medicine, including supplements. And what they found that the users of complementary medicine actually did worse. Again, not cause and effect. This is a complex situation, and part of what the study showed is that sometimes as patients, we may substitute complementary or alternative medicine for more evidence-based practices, and that can end up hurting outcomes. Or it may be that the complementary medicine strategy itself counteracts the positive effects of standard treatment. So the takeaway is that there's a lot of stuff we don't know about supplements and that they may be harmful. I'm going to turn it over now to my colleague Sheila to talk about the next series of myths that are centered on clinical trials. Sheila, it's all yours.
Thank you, Dr. Lesberg. So just a little background with me. I've been on a clinical trial for 3 years. I had a 4th progression in my 4th rib. And my doctor said, well, Sheila, you can go on standard drug, or you can go and try this new clinical trial. And my first thought was, well, am I going to be treated like a guinea pig? So she sat there and she explained it to me, and she called the clinical trial coordinator in, and she explained that there are so many like boards and before it even gets to a clinical trial, scientific reviews before it gets to a clinical trial. So she said, no, you're not going to be a guinea pig. And I was like, okay. I said, I never was presented. It was never presented to me that way. So no, you're not going to be treated as a guinea pig. I get the best standard of care. And it's been great actually being on a clinical trial because I'm able to help further research. As Dr. Gary and Dr. Lamar were talking, they're all for clinical trials as well because this is research, top-notch research that they're trying to find out whether it's going to work. And I'm glad to be a part of that research. So no, after being on it for 3 years, I've never felt like a guinea pig. So, and clinical trials was not a last resort for me. Like I said, my doctor said that she could do a standard of care or we can go with a clinical trial. And I just chose the clinical trial because I trusted my doctor. And I said, well, she suggested it. And she said, no, this is going to be the next best thing out. And I was like, okay. Then she said, well, I got an 80-year-old patient that's on it and she doing really good. And I'm like, well, shoot, I'm young. I could do good if an 80-year-old patient is doing it. So that's why I elected to be on a clinical trial. So. With metastatic breast cancer, they can't give you a placebo or so-called a sugar pill because they have to give you something, whether it's going to be a standard drug that's already FDA approved or whether it's going to be the standard drug plus the drug that they're looking at. So they can't give you, they have to give you some type of medicine or drug. They're not just going to leave you out there. It's almost like, okay, if they give me a placebo, I'm going to die. But no, they have to give you some type of medicine. So that's one of the things that my doctor explained to me. And my clinical trial coordinator, she always says, if you ever want to just back out of this clinical trial because some of the side effects were bad, and she said, you can always back out. You can always change your mind. If it gets, for whatever reason, you can always change your mind. I was like, no, I'm going to stick it out. And my doctor said, no, we're going to stick it out together. And that's the one thing that I love about my doctor was because she introduced me to clinical trials years ago before I even knew what clinical trials were. And that's why I use it as my platform. And I entered, actually, the clinical trial I'm on is DS8210A. 8201A, and it's now FDA approved. It's called InHER2, and I entered the trial in phase 2. And when I looked on clinicaltrials.org, I was the only Black person that entered in phase 2 for this clinical trial. So I was like, well, that made me further want to know, like, why aren't Black women participating in clinical trials? And I also read a study that said that Black women want to participate in clinical trials, but they're sometimes not asked by their oncologists. So I say to any oncologists or doctors or medical professionals out there, just ask your patient and let them be, whether they're Black or whatever race, we deserve the same type of treatment as every other race. So that's why I use my platform for clinical trials.
Thank you, Sheila. And we are happy to, we wanted to make sure there was time for questions either now or in the roundtable. So we're happy to hear from you, and let me kind of turn to the organizers and see how they would like to proceed.
Thank you guys. That was some wonderful information, and just to even get our mindset on the common folklore. So a question to Sheila was, what phase was the clinical trial when you joined it?
I was in phase 2.
And so a lot of times people who are offered clinical trials, they don't understand the phases. Do you have like a quick synopsis of what the different phases are, and will they pick, why they wouldn't pick it or would pick it? Because I know the common thing is if it's a phase 1, you don't want to be in it. Is that true?
Yeah, Dr. Lusberg.
Oh, yes.
Would you like me to, or
Yes.
Sheila, it's up to you.
Oh, you can go ahead.
You're right. Actually, yes. So lots of phases. So phase 1 is when we're trying to do the first human studies and to find the right dose. So you're right. It could be scary. One good thing about phase 1 studies is that there's no randomization. So you're always getting the active drug. And it's important to remember that every good study actually started in phase 1. So I think it's worth a dialogue. It's not always right at every juncture, but it's a good thing for many patients. Phase 2 is when we kind of have a good sense of our dose, but need to generate additional data. So that's where Sheila entered the phase 2 study with the Enhertu drug, where we do want to compare it to other types of treatment, but gain additional data on efficacy. Then phase 3 data are actually the larger studies, typically with 200 or 300 patients or more, where if we show efficacy, they can actually go on to become FDA approved. So your point is completely valid. It's a great question. And I think each phase has its own pros and cons. And that's why to be in a trusting relationship like Sheila described with your healthcare provider, so you can kind of decide at every juncture, is a standard of care treatment better for me or a clinical trial?
Oh, perfect. Sheila, we had a comment for you. It says, thank you for sharing your clinical trial experience. It's incredibly important for people of color to take part in clinical trials. Many oncologists feel clinical trials are a valuable treatment option.
And yes, we have to, as a Black community, we have to participate in clinical trials because now they know, and they're still studying that this drug, I've been on it for 3 years, could potentially, they're looking at my genes as a Black woman. So I appreciate my doctor, and I appreciate researchers and that are trying to further research, and I'm just proud to be a part of it, and part of, now Enhertu is treated, I think, in stomach cancer. And then I was at a conference and it said that Enhertu reduced the risk of disease progression by 72%. Like, wow, I was a part of that, But it's so much more to it than this. And then I was on Herceptin for 8.5 years, but somebody had to been on a clinical trial for me to be on Herceptin for 8.5 years. So it's very important as, Black community. And that's why I go into the community to talk about clinical trials, because they are so important.
Yes. You guys, like Dr. Lesberg and Sheila, you guys really touched on some good components. And I think, like, especially being a Black woman with MBC, I try to help debunk some of that folklore as well. And just trying to have the main thing of lack of assumption. And do you guys think it's a good tool to kind of have for media and industry and clinicians, just to have like a common folklore handbook or some sort of resource when someone gets diagnosed?
Mm-hmm. I think it's a great idea. I don't know if that tool exists, but as I was making this talk, I think it's a good conversation starter, because sometimes we have these ideas in our head, but maybe are afraid to ask. And again, no shame in asking. These are great questions.
Yeah, because oh, go ahead.
And I think that too, when I was diagnosed, and I'm cut it short because I know we're running out of time, but I was given this blue bag and I had to sit in a room for like 4 or 5 hours to watch all these videos about cancer or whatever. So why not include, I don't remember seeing anything about clinical trials, but why not include a PSA or something to say about clinical trials? So you have it in that thought, why not include a clinical trial fact sheet into the bag. I still have the bag. And when you're in the hospital, when you get that blue bag, that means, somebody was just diagnosed with cancer. But there are so many tools that we have already out there that we can use. We just need to use them. We have them. And we have the voices. We just need to use them.
Yes, very important information. I have to say, I was a believer as well that if you cut into, because I had my breast duct removed before I got diagnosed, I was like, well, what if that causes me to have cancer? And I'm a healthcare professional, and I believe that. But I think sometimes things are just embedded into us culturally, especially in the Black community. Now I have a better awareness and understanding, and now I can better explain it to my family and friends. But you guys, this was wonderful. I really appreciate you taking the time to discuss this. The more we know, the better we can be.
Thank you, Shanta. You're doing such a wonderful job.
Oh,
thank you, Dr. Lesberg, for inviting me to be a part of this panel, and METAvivor, all that you're doing. I just appreciate it all.
Maybe we can do a myth handout together with MetaVivor.
Yes.
Yes.
I'm
Hey, see how the universe works.
for that.
Thank you.
You're welcome.
Bye.
Bye.